Hello, David Fitzgerald here of Dublin Physiotherapy. Today I'd like to discuss 10 questions with you that you should ask your physiotherapist to make sure that you're getting the best possible care. And this is not necessarily in order of priority, and you don't necessarily have to go in with a bullet point list and ask all these questions as soon as you walk in the door. But first and reasonable question is, have they seen the kind of condition that you have before, and have they experienced in treating it? That's important because there are different specialties within physiotherapy, whether it's care of the elderly, geriatrics, joint replacements, sports injury rehab, occupational injury. The list goes on and on. So it really depends on the nature of your condition as to whether that's an area that the physiotherapist that you're seeing specializes in. And obviously, if you want to get the best care, you want to see people who are specializing in the particular condition that you have. So that's not an unreasonable question to ask. And then it usually leads on to another question in terms of how successful is treatment for this type of condition. So that's a perfectly reasonable question to ask. There are usually established time scales that people can tell you. If it's an anterior cruciate repair, you're usually looking at 3 to 4 months for running, 5 to 6 months for twisting and turning and pivoting, 6 to 7 months to hopping and jumping and return to play, maybe 8 to 9 months. So that's a fairly well-defined kind of a situation. Hip replacement, you're looking at trying to wean off crutches in 3 to 4 weeks. So if you're outside of that window, then things aren't going to plan. If you've had an acute episode of low back pain, then it's a case of gauging, what's the stage of recovery? Is the trajectory a steep recovery of improvement or a much slower, much more cautious one? And that's a very individual thing depending on the person involved. Of course, the big question, and we've discussed this in videos before, is this a condition that physiotherapy is appropriate for, or do other kind of treatments need to be involved? Either surgical treatments. So obviously that's an ethical issue for the physiotherapist to identify conditions where, surgery is the necessary option and the obligatory option. So the physiotherapist who may be the first point of contact is obliged to be able to recognize that. And if they don't recognize it, essentially it's negligent if there are obvious signs. Very often there are people who are borderline, and you may well discuss the options of getting a surgical consult, and they may well say, well, look, I'll prioritize trying to manage conservatively and see if things resolve. And that's a fair approach. But as a clinician, you do need to see some structured progressive change in the shorter term, certainly over 3 to 4 treatments. If you're not really seeing a change in symptom severity or functional capacity over 3 or 4 treatments, then really one would have to question whether one's being of any help at all. So comparing where you are with known timescales. Now, obviously, that's a grey area. People with degenerate joint problems, sometimes you're trying to make the best of a compromised situation. So you may be exploring new territory when you're trying to get people back to activity levels that they want to, whether that's hill walking or playing golf or casual tennis or whatever their chosen activity is. So sometimes you have to work systematically through milestones, and if people don't achieve milestone A, they're unlikely to go on to achieve milestone B. So that's a practical reality. But that's definitely one of those situations where it's a case of not being able to walk before you can crawl. So it's really, if you don't achieve a lesser milestone, it's highly unlikely that you'll progress to achieving a more complex milestone. So another point would be, what would the alternative treatments be? So I've partly touched on that if there is a surgical option required, then that's really important that the physiotherapist recognizes that. Now, the other thing is, what are described as confounding variables or confounding variables. Sometimes your individual circumstances, whether it's your general fitness, whether it's carrying extra weight, whether it's medical conditions, occupational factors, all of these factors determine your rates of recovery, your prognosis, and how you respond to a specific injury. So one has to factor all of those things in: your own body makeup, your own biomechanics, which is the mechanics of how you move. So all of those variables are all chucked into the mix, and unfortunately it's not a precise science to know how they all work together. But a competent physiotherapist should identify all the variables and try to prioritize them, whether they need to be pursued or not. Or sometimes it's only when you work your way into a rehabilitation program that you can start to say, okay, well, maybe the lack of strength is a more important factor here than we initially thought, and we need to change our priority from manipulation or manual therapy or stretching into more of a strength focused type of program. Or if people are fatiguing because they have a thyroid issue or some other medical issue, then that can be a factor causing a plateau. So they need to be recognized, and obviously collaboration with other health professionals will be important. Another question we often get asked, but people should ask, is, how do I know when I've plateaued? So if it's a condition that maybe there won't be a complete cure for, it's just a condition that you're trying to make the best of, how do you know when you've reached that point? And the answer really is you don't know until you've reached it. It's very hard just from physical examination and response to treatment to gauge, what someone's full capacity is. You can tell them, from a degenerate knee that it's never going to take the same load and work capacity as the healthy knee. But what precisely those limits are, you only ever know by exploring the limits. And some people are a bit reserved about doing that. Some therapists are reserved about that. In fact, there's a lot of research that would say that the therapist's attitudes profoundly influence their approach to rehabilitation. So if somebody is naturally very conservative, they'll tell you a long list of things not to do. And my view would be that really long lists of not to do things are only appropriate if it's absolutely clear that they're causing a problem or that they provoke symptoms, and it's unlikely that you can be rehabilitated to be able to do them. But my view would be that the role of rehabilitation is to try to enhance your capacity as best you can in as many dimensions of life that you want to pursue. That is to some extent a personal philosophy of the therapist that you're treating. So that's a reasonable question, but in practice, it's usually if you see someone who remains the same status for 2 or 3 successive reviews, so there's no change in their clinical signs, there's no change in their symptoms, and there's no change in their functional capacity. So the question then is that the limit of their full potential? Or from a therapist's point of view, is there anything that you may have missed that could potentially enhance things more? So that obviously is incumbent on the therapist to self-reflect on the combinations of treatments that they've offered. They also need to be aware if there are other interventions, and we've talked about this before, non-surgical interventions like pain management procedures, injections, medications, and or whether, as I say, coexisting medical conditions might be compromising things. So that's another question that is a reasonable one to ask, and I have a list of things here. I'm working my way steadily through the list. Yes, another reasonable one is, well, how do I maintain what I've got? Obviously, people want to try and be as independent of healthcare providers as they can. So if it's a chronic condition, as therapists, we'll try and prescribe a maintenance program to try and maintain people's status. And life being life, people often stick with it for a few weeks or a month or 2 and then let things go if they're holding fairly stable. And they may well get away with that for a number of months. And then things start to return. And sometimes they can get back on track just by going back through their exercise programs, or sometimes they need little booster sessions of treatment periodically. And I would see a lot of patients who benefit from periodic boosters every few months. And that's just something that we've worked out over trial and error, that if we just leave them to their own devices, they gradually start to develop more symptoms, and their home exercise program controls it but doesn't prevent it. So that's again a situation that you can only determine when you reach it, really. But sometimes it's worthwhile trying to work out that pattern, because if things are allowed to slip back, often it can take a more intense effort of one-on-one treatments to regain the lost ground. So sometimes people find it better just to do periodic maintenance rather than seeing how they go and then things getting provoked, and then it takes a while to get it back on track. Now, that all is presuming that you have a chronic condition, not a condition that can be fully rehabilitated. And once it's rehabilitated and you return to normal function, then by and large, that's you. You can forget about it and get on with living your life. And how, another question I think which is a reasonable one, is that if I can't do the activities that I want to do, what are the alternatives? And that's an important combined decision that the therapist needs to make with the patient. So if they can't run, then maybe walking is an alternative. If they can't walk, would cycling be an option, or swimming, or yoga, or some modification of classes? So it is important to try to find some alternatives or some ways of working the system to maintain health, even if it's not people's chosen desire. Other people will take the view that, look, I like playing casual tennis once a week. I'm a bit stiff and sore for a day afterwards. I already have a degenerate hip or a knee. It's not going to resolve. Will probably end up requiring surgery. So I'm going to enjoy the quality of life that I can do until it gets to a point where the level of pain is too much, or the residual effects of doing what they want to do is just too much, and they're forced into a decision. And that's a perfectly valid approach. In orthopedics, you're generally not looking at life-threatening conditions, so it's not a case of saying, you must do this procedure now. It's often a case of just trying to maximize the mileage and the capacity and doing the best that you can. So I think that's a list of 10 points. I think, as I say, you don't necessarily have to go in systematically and interview the therapist. Very often people will have done their background research anyway to know what the therapist's expertise is and what their philosophy of care is. So some of these questions may well have been asked casually by people who have attended before. But I thought they're worthwhile points. And one, the final point I'd like to mention is that it's a very reasonable question to ask whether the therapist is treating symptoms or causes. Now, obviously, when you present for treatment, invariably it's because you've got discomfort and you're in pain, so you want your symptoms treated, but you also want to try to prevent recurrences. So it is important, and the therapist should be relaying their thought processes to you as they're working through a rehab program with you. But if you're just treating symptoms, then obviously there's not a great chance that you're going to prevent a problem returning. So that's a valid sort of question. And if we look at the analogy of cardiac care, if someone presents to an A&E with chest pain and loss of consciousness, you don't start lecturing them on diet and lifestyle and exercise. You treat the acute symptoms in whatever medical way is necessary. And the same would apply to musculoskeletal health. But at some point, there's a transition between treating symptoms and then trying to address the variable multifactorial causes that often contribute to long-standing problems. So that's another valid question. So whether we've got 8 or 10 or 11 points there, I think it's more than enough for you to consider. And I think they're valid points and ones that you should have a discussion with your therapist. Hope you enjoyed the content. I'll see you again on another video. Bye for now.